Welcome back. We are now focusing on total hip arthroplasty or hip replacement. Postoperative nursing care focuses on 4 responsibilities. These include preventing complications of neurovascular status, infection, dislocation, and mobility. Now, can you name a medication that prevents blood clots as a neurovascular complication? We can use Lovenox or heparin post-surgical to prevent blood clots. This is a pharmacological intervention that nurses can do to prevent neurovascular complications. Non-pharmacological interventions for neurovascular include the 5 Ps. We use our 5 Ps just as we would with fractures to prevent complications with hip replacements. Drug therapy. For infection prevention, the pharmacological intervention includes administering antibiotics in a timely manner. Non-pharmacological, we can think of external fixators. We're going to watch for signs of infection: redness, inflammation, purulent drainage. Dislocation and mobility. Now, with dislocation, I have an interesting story. I had a patient who came into the hospital because his hip kept dislocating and then popping back in by itself. I would walk into his room and the hip was in the place where it was supposed to be, and his legs were aligned. They were not unnaturally rotated. There was no crepitus, but he definitely was in pain. I came in a few minutes later. The hip was out of place again. I heard the popping sound, the crepitus, and the deformity was there. The cardinal signs of deformity and crepitus were evident when I walked in when the hip popped out. So he had to go in for a hip revision because you can't have your hip popping in and out of place like that. How do we prevent a hip replacement from popping out of place? There's 3 basic rules. We have to keep the hips higher than the knees. Do not allow the patient to cross their legs and keep their toes forward. Do not turn their toes inward. That would help to pop the hip out of place. When we are turning a patient on their side to reduce pressure ulcers or we shift them, basically to complete some hygiene, we do not turn the patient on the side of the surgery. That would cause too much pain and too much movement of the hip. Mobility requires the same amount of coordination as we did with fractures. Try to coordinate meal times or nutrition and the dietary choices, physical therapy, and pain management all together. You don't want them to be too sedated to get out of bed to chair with physical therapy. You want to make sure their meals are going to help them heal. You have to coordinate all of those things to help the patient. Can you name one neurovascular complication from a hip replacement? Again, we're talking about the 5 Ps. Is there pain with passive motion of that hip? Do you see some pallor, cyanosis, paleness, or coolness at the hip? Is there numbness or paresthesia at the site? How are the pulses on the toes of the side that was repaired? Is the pulse faint? Is there pulselessness? Is that side hard to move? Now, we don't want to pop the hip out of place, but it shouldn't be too tense, or patients should not be suffering from paralysis of that leg. Those are all signs of neurovascular complication. Again, we talk about the 5 Ps often because as a nurse, 5 Ps are your power to prevent complications for your patient. We are focusing on quality patient outcomes for our patients that have had hip replacements. In the beginning of this lecture, we talked about the aging population that we will be taking care of, and that they will be facing these complications or these diagnoses as older patients. There are some considerations for older patients that nurses have to understand may occur and we will have to manage for our patients. To prevent pneumonia, we are going to encourage our patients to cough and deep breathe, and we can also give them the incentive spirometer to work with every hour and keep a track of how far they go in the incentive spirometer and encourage them to go a little farther every day that you're with them. Skin integrity. The skin integrity of older patients is at higher risk than younger patients because their skin tends to be drier and thinner. They're going to be laying in bed a lot. We are going to try to get them out of bed within the 24 hours, but with older patients, it's harder to heal. They're going to really want to lay in bed. So what you're going to want to do is shift them as much as you can back and forth in the bed, rotate to different sides, of course, making sure not to put them on the side of the surgery with hips. And you're going to want to elevate their heels on pillows. Older patients are at an increased risk for fall because of altered mental status due to coming back from anesthesia, pain medication not clearing out of the kidneys as fast as it would because of creatinine clearance. So we're going to make sure we have on our bed alarms, and we're going to constantly reorient that patient, let them know where they are, the date, the time. If family can come in, make sure the family is there so they can see a familiar face. The family can come and help to feed them, talk to them, encourage them to get out of bed to chair when physical therapy is there. Immobility. Again, get them out of bed to chair, work of physical therapy, manage their pain with assessing them regularly. They may not be able to tell you that they're in pain because of the altered mental status, recovering from anesthesia. Assess their pain, look at their facial expressions. Are they wincing? Are they guarding? Make sure you get them moving and managing their pain. Those are some of the considerations for older patients. Following hip replacement surgery, pain management is a priority for nursing care. For older patients receiving narcotic analgesics such as morphine, we usually will be giving a reduced dose because of older patients' physiological challenges and our desire to reduce side effects for the patient. This is a morphine label. We are going to calculate the reduced amount we would be giving a patient 12 hours post-surgical. The answer is 15 ml. Knee replacements are within the discussion of hip replacement because you're going to be looking at the same prevention measures for complications. These are neurovascular, infection, dislocation, and mobility. Neurovascular, again, we're going to be checking on our 5 Ps. Infection, we're going to be looking at the site to make sure that we don't see any redness, swelling, signs of purulent drainage. We're going to be giving our antibiotics, the post-op antibiotics, on time. Dislocation, with knee replacements, that's less of an issue than you would have with hip replacements. But again, you do not want to rotate the legs in and out. You do not want the legs in an unnatural position. Try to keep the toes facing forward. Mobility and dislocation have to do with working with physical therapy. They're going to want to teach the patient the best way to move, not to aggravate their knee replacement. In terms of mobility, physical therapy combined with pain management and nutrition, just like we did with hip replacements, you're going to try to combine those 3 things to encourage the patient to get out of bed, especially post-op day 1, within 24 hours of having the surgery. Make sure that the knee pain is managed with cryotherapy, like surgeons usually order, which would be an ice or a gel pack on the knee. And if there's any opioid analgesics or that we need to give to the patient, that is done coordinated with physical therapy to make sure the patient refuses to get out of bed because they are in pain when physical therapy shows up, and that they have a nutritious diet that is going to help their knee heal.